I hope that you've had the opportunity to look at the previous video that we produced on the history of medical missions and the importance of it and how it has been an intricate part of mission work for many, many years. We also need to look today at the emphasis of medical missions that is important to the church missions program around the world. There are basically 4 different types of mission works. We use 3 of these. First of all, there's a Tier 1, and in the Tier 1 mission work, there is basically a short-term mentality. That short term could be anywhere from 10 days to 2 weeks, possibly maybe 3 weeks, but not much more than that, because the medical people cannot afford to give us that much time. A place is picked out, people volunteer usually once a year, and they go to these various countries. They conduct a temporary clinic, and then they return to the United States. During the time that they're in the country, they become the source of drawing people to the clinic, where there will be some type of gospel presentation given, and the missionary will be responsible to follow up that work. Now that's Tier 1, and about 23 years ago, Operation Renewed Hope began to do that tier of work for medical missions for the modern day. For fundamental churches, as we would call them, this was somewhat new. There was no one for us to go to and ask about how to do this. But then there's Tier 2. The second tier of medical missions is the medical professional surrendering to the mission field and then going to that field and living there, acting as both missionary and doctor or nurse or whatever might be the case with their medical capabilities. Now, there is no special mission program for that. Probably one of the most impressive mission programs has been the ABWE mission program that was worked out in the 60s through the 90s basically, and has been very effective as a mission program of the church. Today, very few medical doctors leave the United States, go to another country and live there and do mission work as medical. Then there is the third tier. The third tier of medical missions has always been a short-term surgical team or specialty team that would schedule in a location someplace, send in people to evaluate people for surgery or whatever, such as cleft palates, that type of thing, heart surgeries, different types of specialties. They would conduct their services inside a hospital that exists inside the country. There would be evangelism, but basically it would be to the family that was being helped, and it is a very limited evangelism because only so much specialty work can be done in the period of time. But it leaves a lasting impression in the lives of the people that there is great love and compassion from Christ through these wonderful servants who give of their time. But once again, it is a purely temporary program of just a few days, and then the medical person is back in the United States. Now, over the years, there has been a new development that has taken place in the actual medical structure of the United States. For years you had a very strong line of demarcation drawn between nurses and medical people that would be below them and doctors. There was a very strong line drawn. Then you had another line which was the specialists. So you had nurses, general practitioners, and then you had specialists. And this is an oversimplification, but it works for our purposes. Now, what has happened? First of all, the general practitioner is a very scarce commodity today. For the most part, doctors are having to specialize so they can pay for the very expensive education that they must receive. And for the length of the education, they are in a very difficult situation there, because it takes 8 to 12 years of very hard work to get to the point where they can be considered a quality doctor, a trusted doctor, and a specialist may even take more time than that as they develop their skills in the specialty that they have chosen. So this gives us a very difficult situation in the United States, because we have demand for health care which is increasing greatly. We have fewer caregivers, fewer general practitioners, more people going into specialties. And it is very difficult for our medical structure to have such a low number of general practitioners. So what occurred? This is what occurred. The United States structure began to change to what we call mid-level providers. The mid-level providers are those people that would go from nursing to some type of ability to examine patients, to prescribe treatment, to diagnose, and then also to prescribe medicine if medicine would be needed. On the nursing side, it was called a nurse practitioner. But as a result of World War II and all the medics coming out of the wars, and then also medics coming out of Vietnam, Korea, different places, these people wanted to be able to use their skills when they came back as medical professionals. So then you developed the paramedic and the EMT. Many of the people settled in that. But after years of doing that, they wanted to do more. And so now they have developed the physician's assistant. So after years of experience, then you could go to a program of a graduate program and possibly receive the help that you needed to be a person who could diagnose, treat, and prescribe medicine. So those two mid-level providers are an important part of the scheme of medical missions today. I would like to create a tier in between the first tier, which is general short-term clinic, and also the missionary doctor who goes to the country and stays there. What is the tier in between? Well, it's the same tier that's happened inside our country. It's mid-level providers. What is the benefit to having a new second tier and pushing the permanent missionary doctor to a third tier, creating 4 total tiers of medical missions? The benefit is this. Number one, it takes less time to get a nurse practitioner or a physician's assistant finished in their degree so that they can do the work that is necessary. Second, there is absolutely a great savings financially to the people, because they do not have to pay the high costs that is associated with medical today. And they are able to walk away with less debt, but at the same time have some of the same skills that a general practitioner has. Can they practice medicine alone? Not in the United States. In the United States, they would have to work under a general practitioner. But most of our clinics today are being staffed by people who are mid-level providers, nurse practitioners, and physician's assistants.